welcome back to the UBC Learning Circle, hosted by the Center for Excellence in Indigenous Health. We are very pleased today to be joined in circle by Dr. Terri Aldred, Dr. Kendall, and Dr. James Liu. Today, we're all going to be discussing cultural safety in acute care settings, some of the initiatives that we've been there, that the circle has been involved in, and what our kind of contemporary reality is. So before I get into anything else, I would like to acknowledge that I'm zooming in from the traditional, ancestral, unceded, and occupied territories of the Hunkaminam-speaking Musqueam people. I would also like to acknowledge the First Nations Health Authority for generously funding the UBC Learning Circle. So gentle reminder here, the topics we cover can sometimes be sensitive or emotionally triggering. If that's you for today, please make sure that you're looking after yourself. Access your support network, whatever that looks like. If you need to talk to an elder or a friend, family member, counselor, please do so. So introductions. My name is Cole. I'm from the Chowthil First Nation. I'll be facilitating the session today. Other Learning Circle team members in the room, but off camera are Cynthia, our production coordinator, and Winona, our program assistant. And if you feel so inclined, please introduce yourself in the chat box. We'll kind of get the dialogue started in that way. With that, I will pass the baton, as it were, over to Dr. James Liu to get us started.
Good morning. My name is James Liu. Thanks so much for having me here today. I'm an emergency physician at Langley Memorial Hospital, and I'm also a primary care physician with the Sekani Family Services, which is a nonprofit organization providing First Nations communities in central northern BC with interdisciplinary primary care. And can I request the slides? Next slide, please. So I would first of all like to acknowledge that I live and work on the traditional and unceded territory of the Kwantlen, Musqueam, Katsi, Semiahmoo, Tsawwassen, Kaiket, and Coquitlam peoples. Next slide, please. I do not have any conflict of interest to disclose. I'd also like to acknowledge that I do not possess any lived experience from an Indigenous perspective, as I'm an Asian settler. And speaking about Indigenous health from the lens of a non-Indigenous healthcare provider is not an attempt to add validity to Indigenous voices. These voices are intrinsically valid and do not require further validation by a person without lived experience. And the focus of my presentation is on the deficits of the current healthcare system in assessing its performance in Indigenous health. The deficit lies with the system and not with the patients, nor with the communities. It does not claim to represent Indigenous values on health and healthcare. And finally, this presentation contains material that benefited from the expert input of Dr. Terri Aldred. Next slide, please. There exists a large health gap between the health of Indigenous peoples in Canada and non-Indigenous Canadians. This gap is made more obvious when comparing Canada with peer countries, such as those in the OECD countries here that you can see. The life expectancy for Canada overall is 81.7 years. And when you split out the life expectancy of Indigenous persons in Canada, that goes to 75.7 years, which is actually comparable to a country like Hungary and is significantly below the OECD average of 80.5 years. And next slide, please. Other markers looking at the performance of the healthcare system includes the risk of dying from avoidable causes. And First Nations adults have been shown to have more than double the risk of dying from avoidable causes compared to non-Indigenous Canadians. Next slide, please. These gaps are also seen across other outcome measures for specific conditions like heart attack or graft rejection rate after a kidney transplant, and therefore having an unsuccessful kidney transplant, as well as a risk of dying after having a hip fracture. So together, these findings demonstrate the fact that the Canadian healthcare system performs poorly for Indigenous peoples in Canada. Next slide, please. There's increasing recognition that Indigenous peoples in Canada face disproportionate disadvantage through the building blocks of health, known as the social determinants of health. The proximal determinants that you can see there, such as health behavior, physical environment, employment income, education and food security, immediately and directly affect health. Whereas the intermediate determinants like the healthcare system, education system, and societal infrastructure, etc., they affect the proximal determinants. And the distal determinants like racism and colonialism, self-determination, they exert an effect through the intermediate and the proximal determinants of health. And taken together, the amount of societal inequity that Indigenous peoples face in Canada has been described as structural violence, where social structures harm people by preventing people from meeting basic needs. Next slide. Understanding the determinants of health can shed light on the origins of the health gap that we can see across the population, like those numbers that we just saw. But it represents only part of the pathway that leads to this health gap. We can conceptualize this pathway by taking a look at this graph here. At birth, there's some difference in health that's already observed that shows itself, such as low birth weight. And with age, the determinants of health that we talked about, as well as systemic racism, structural violence, and the impact of trauma, exert stress on the body and accelerate the development of various illnesses. A lack of cultural safety in healthcare means that Indigenous patients experience discrimination and unequal treatment. And this may cause a failure to close the health gap or potentially to even worsen the health gap, ultimately leading to the population-wide health gap that we can see in those numbers that we saw earlier. And we'll focus our discussion today on this portion of the health gap within the healthcare system. Next slide, please. The recent report by Mary Ellen Turpel-Lafon, titled In Plain Sight, examined the anti-Indigenous racism across the BC healthcare system and found evidence of widespread culturally unsafe care. Seen here, for example, when asked the feeling of safety in healthcare settings across the different settings, Indigenous peoples are 3.5 times more likely to feel not at all safe and 50% as likely to feel completely safe in hospital settings compared to non-Indigenous peoples. Next slide, please. The feeling of lack of safety in healthcare spans a number of different acute care disciplines and services. As you can see, it's not limited to a specific discipline. It can include physicians, it can include social workers, it can include security, the discharge planning process. It can span all aspects of acute care. And of note, women are significantly less likely to feel safe in most of these settings. Next slide, please. When asked about specific types of poor experiences, Indigenous people were, in the survey, were much more likely to have specific negative experience, such as being assumed to be intoxicated, or much less likely to have positive experiences like being treated with courtesy and respect. Next slide, please. The survey also found evidence of widespread anti-Indigenous stereotyping within the BC healthcare system, such as being less worthy of care, as well as other stereotypes, and that's quite pervasive. And next slide, please. Here's an example of a quote. I notice when some nurses find out, they look at you and they see your First Nations and their attitude changes. You can hear them. And you're in the emergency room and they're talking real nice to someone who's not a native, and then they come into me and their attitude changes. So it's not all like that, but I run into that quite a bit. And this is a quote from a 57-year-old woman on the provider's attitudes that was shared during a qualitative research study. Next slide, please. There's a number of other examples of poor experiences that were found in the report, including unacceptable personal interactions, disparaging remarks, failure of communication or minimizing concerns, to inappropriate pain management, and overall producing numerous examples of poor experience. Next slide, please. The report was also able to measure and quantify and put into numbers some of these poor experiences. For example, when admitted to hospitals, First Nations patients tended to wait longer in the emergency department before going up into a medical ward. There are also higher rates of people needing to come back to the emergency department within 48 hours of a previous visit to the emergency department. And also, First Nations patients had a higher rate of leaving the emergency department being seen without being seen by a physician, and which can be from a number of different reasons. And more research is needed to take a look at why that is the case. But some have hypothesized that poor experience in the waiting room could contribute to this gap. Next slide, please. And seen here, some Indigenous people have indicated that they avoid seeking healthcare as a result of these negative experiences. And the quote here, "I'm afraid to go to any hospital. When I do have to, I dress up like I'm going to church in order to receive proper treatment." Next slide, please. These negative experiences are, while sometimes they are portrayed in the media in the extreme form with catastrophic outcomes, unfortunately, these negative experiences also capture those experiences that are described by people on an everyday basis in the form of microaggressions. And these negative experiences do have a human cost. It serves as a barrier to access healthcare. And people have been known to vote with their feet and exit care early. As you can see here, leaving against hospital against medical advice 2.6 times more than non-Indigenous patients. And not surprisingly, this contributes to Indigenous peoples having unmet health needs. And it's even been shown that First Nations people who feel that their care is not culturally safe actually unfortunately have a higher rate of having diabetes. Next slide, please. There are many drivers of these gaps that we've just discussed. One factor is increasingly being reflected upon by healthcare providers will be the phenomenon of unconscious bias. And this is also known as implicit bias. So implicit bias involves association outside of one's conscious awareness and control. These are linkages between ideas and concepts that a person may not even be aware of or be able to control. And the linkages could form early in life because of personal experiences or just the environment. And these linkages can often exist between stereotypes and negative assessments in groups of people. And they may lead to a negative perception of a person, even on the basis of completely irrelevant characteristics. And what's interesting is that these biases that are unconscious may not actually correspond with what the person say or even think that they believe on an outward basis. Next slide, please. And so when studying this phenomenon in healthcare workers, there is evidence that implicit bias exists in healthcare professionals. And it happens at about the same amount as it does to the rest of the population. And there has been found to be some significant relationships between implicit bias and lower quality of care. Next slide, please. And implicit bias has been found in some studies to be related to be contributing to poor interactions between the healthcare provider and the patients. Sometimes even treatment decisions, the ability, the willingness for the patient to accept the treatment, as well as ultimately healthcare outcomes. And the studies also have found that most healthcare workers, regardless of ethnicity and race, have a pro-white bias and negative attitude towards people of color. One positive change that is occurring, though, is that there has been an increasing discussion around implicit bias amongst healthcare workers in looking for ways to reduce the impact of implicit bias on the care they provide. And this has also been beginning to be incorporated into different training that healthcare worker is exposed to. And for example, the SANIA's cultural safety course. And over time, this may help shift the direction towards health equity. Next slide, please. Another opportunity here to be seen is that people seem to feel slightly less unsafe in doctors' offices. Looking at the slide that we were seeing there before. Next slide, please. And there does appear to be room to improve access to healthcare, to family physicians for Indigenous peoples in the community. And as you can see here, this graph basically compares the proportion of the people who have family doctors or who do not have family doctors, rather. And you can see that that number is higher for First Nations people than non-First Nations people across all different age groups. Next slide, please. And this unfortunately means that there's needs that are unmet in the community. And so, for example, prevention, as well as other testing that happens in the community, this is the access is poorer. And not surprisingly, this requires more visits into acute care, such as emergencies. And next slide, please. And interestingly, in studying this phenomenon in Ontario, it's seen that this actually is related to people needing to become admitted to hospital for conditions or situations that otherwise wouldn't have needed hospitalization if the care needs were met in the community. And this seems to be happening with, for example, people with diabetes or people with lung conditions at almost twice the rate as non-Indigenous people. Next slide, please. And so indeed, First Nations people who have family doctors do tend to have lower rates of visiting the emergency department, as you can see here, comparing the first two bars looking at First Nations people who don't have family doctors versus people who do, but then comparing non-First Nations people. And so this obviously does not completely close the gap, but does offer one opportunity for action. And so one thing to be clear is that this is not to say the onus should be on Indigenous people to find more family doctors in the community. The onus is really on the healthcare system to make primary care safer and more accessible in the community, which has value in improving health outcome for Indigenous people beyond just the short term and into the long term. And therefore, there are also a lot of current barriers for Indigenous people in seeking primary care right now, including the potential for being less likely to be accepted, having poor cultural safety, clinical policy, or even just distances to other things that people may have to do, like, for example, going to the lab or getting x-rays. And all of these reasons could make it harder for people to get family doctors. And so again, this demands a push to improve access to family doctors in the community for Indigenous peoples in Canada. And next slide, please. So overall, there continues to be a number of areas for improvement in cultural safety in the setting of acute care. And more these concerns are being measured and documented, which hopefully may allow opportunities to target specific improvements and specific opportunities. And some of these opportunities include increasing collaboration between healthcare providers and community members in looking for ways to meet healthcare needs in a more culturally safe way and to develop accountability. And other actions at the provider level includes more training on cultural safety and conscious biases and trauma-informed care. And over time, we hope to continue to work together to transform the cultural safety of the healthcare system. And on a personal note, I'd also like to acknowledge that it's been tremendously painful as a non-Indigenous healthcare provider to review the inequities that exist in healthcare for Indigenous peoples in medicine. And when I first went into the field of medicine, I had always considered healthcare to be a place where people can heal. All people can heal together in order to go out and then face an unequal world, which may not treat everybody equitably. And therefore, it's been quite difficult to examine this area of cultural safety and health inequity affecting Indigenous people, and to really confront the fact that the system that I work in may not necessarily offer the same sense of safety to all people, in particular to Indigenous people, as I would feel if I was a patient myself. And so that, however, what has been heartening is to see an increasing number of healthcare providers who are becoming more concerned about these issues and showing a willingness to learn. And so we will be turning to you in growing numbers to learn from you and to work together to build towards a critical mass. And we hope to then transform the healthcare system into one that's more equitable. Thank you very much.
Great. Thank you, Dr. Liu. That was fantastic. You know, I struggle with the words because, you know, my first thought was that it was illuminating, but to me, it's not illuminating. It's just reaffirming. And I wanted to say here before, there are a few kind of direct questions I wanted to address to you based on your presentation, but I wanted to say that I think it's important that knowledge translation is a really important skill, and that communication amongst professionals and across, let's say, gaps and barriers is critical. What you've shared with us today, I don't think it's news, and we can scroll through the chat and see many community members that are echoing my sentiments here. It's not news to us as Indigenous people, but what's, I think, important about the work is that it tries to take those experiences and present them in a way that is digestible for physicians, kind of speaks the language of healthcare. You know what I mean? In terms of kind of breaking things down to statistics and the reality of kind of moving forward in different plans and really breaking things down into rates so that professionals can better understand the systemic issues that we face. So I thank you very much for the presentation. It was illuminating. One question we had from a community member was on whether or not you have there been any studies or is there any data on impacts of Indigenous people who have access to village clinics, so community physicians conducting weekly visits to rural and remote villages. Did you include any of that data in your presentation? And if so, are you aware if that makes an impact at all on anything you've chatted about?
Thank you for the question. Yeah, and also just to go back prior to this question, just to go back and also just affirm what you said there, Cole, just about, you know, describing these phenomenons really is not about sharing new things. I think the pain, I think the experiences have all been there, and they don't, like I mentioned earlier, they do not require further validation. They exist. People know this very well, and I think merely it's putting into a different language and adding, you know, adding numbers to these things merely makes it, like you said, more digestible for a specific population, and certainly not meant to be trying to validate or you know, in any way to make more credible, etc., of people's experiences, which people know very well. And with regards to the question, I did not include those numbers. And yes, there are some studies showing that with regular primary care visits, it actually does bring the outcome slightly closer, actually, to non-Indigenous communities that are comparable in terms of other markers, like, for example, how rural a community is. So there are some studies that show with improved primary care, it does make a difference. Based on my last recollection, I don't know that the gap entirely closes, but it certainly moves significantly in the right direction.
Awesome. Thanks, Dr. Liu. So we have, so I see a bunch of other questions in the chat. I appreciate it. I wanted to take a moment here to say that we're going to kind of go through Dr. Liu, Dr. Aldred, and Dr. Ho, and then kind of all circulate back around for a wider discussion. So any of the questions that I don't address here, we're going to come back to with all of our panelists to kind of weigh in on it together. So thanks very much. And I think we'll transition to Dr. Aldred. Terri, do you want to take us away here?
Hello. Hopefully everybody can see those slides okay. So Hadit, my name is Terri Aldred. I'm mixed race on both sides of my family. I'm Dacath and Swiss on my mom's side, and mixed European and Métis Cree on my dad's side. Being matriarchal people, I was raised and brought up as Dacath from Clasden, a member of Lasilu, the Frog Clan, traditionally known as the Voice of the People. My traditional territory is located just north of Fort St. James, and I have the honor and privilege to be calling in today from the Lheidli today traditional territory, otherwise known as Prince George, which is the photo that you see on the right there. This is just overlooking the Fraser River and Claytley Tene Memorial Park. And just to the right of the picture is where Claytley gets its name, where two rivers meet, so where the Nechako meets the Fraser. And this is a picture of me with my maternal grandmother, Shirley Prince. And I just always feel like it's important to carry my family with me. Thank you for those who are introducing yourselves in the chat. I see there's lots of Northerners, which is great to see. So I'll try to address some of the questions that have come up. There we go. So today I'm going to talk a little bit about the Terri Sekani Family Services Program, where I've been a primary care physician for the last 7 years. Dr. James Liu has also worked with us, and also the UBC Indigenous Family Medicine Program. And as kind of highlights on how we are trying to address some of the implicit biases and some of the harm that the healthcare system has done. So I'm an alumni from the, and I'm sorry, I always forget to finish my introduction with saying I'm a family doc by trade. And I have a few different roles. One is as the site director for the UBC Indigenous Family Medicine Program. I'm also the medical director for primary care for FNHA, and I work with the Rural Coordination Center of BC. And do my primary care through Terri Sekani. So apologies for that. So I'm an alumni from the UBC Indigenous Family Medicine Program. It started in 2002. Our first graduates from that program are somewhat famous, Dr. Evan Adams and Dr. Shannon Waters. So it's gone through many iterations of the program. At this point, we are a distributed program where our residents are based both on Vancouver Island and Vancouver. In Vancouver, our residents work in clinics in the downtown east side, and they also do outreach with Terri Sekani Family Services. You'll see that picture on the right-hand side is of one of our residents up in Takla, receiving some teachings from the elder. And the picture on the left is our residents gathered in Luma, which is one of their clinics that they work out of in Vancouver. On Vancouver Island, our residents work in Victoria, Duncan, and Ladysmith. Our program calls in residents who either have, they all have a passion for Indigenous health, for social justice, and health equity. And we generally have a mix of about half and half. So half of our residents are Indigenous and half are non-Indigenous. And we essentially, it's the only program of its kind in Canada, and actually we think the world still, which is very unfortunate in my opinion, because we're the only program that really roots the core parts of our program is rooted in family medicine clinics with preceptors who have built good relationships with the communities that they serve, and who demonstrate how to have a good ethical space and build and continue to build relationships with their communities. And so our core part of our family practice program is Indigenous health, is health equity, is teaching the knowledge and skills that people need to be successful in helping to address healthcare disparities, which is different than many programs which usually have, the regular family medicine, and then you can go and take like a fellowship, or you can take some electives in Indigenous health. Whereas really our core, our foundation is Indigenous health. And then we borrow from our associated sites and regions to ensure that our residents graduate able to do full scope family medicine. And recently on some informal polls. We're working on doing a formal evaluation. We hope to publish about the program, but informally, we found that 70% of our graduates actually usually hold roles both in urban centers, often working in places like academia, inner city, addictions, but also hold roles in rural remote areas and do outreach to First Nations communities. And so we have been very successful in helping to nurture learners into working in and with Indigenous communities, um, both on reserve but also in our urban and away from home populations. And so our core functions of our program is around building ethical space, which I'll touch on in just a little bit. But we have elders that work with our program, Elder Roberta Price, as well as Elder Bill White has recently joined our program from the island. To help guide and nurture our residents and ensure that our program is aligning well with Indigenous values. And we also, before COVID, used to spend every 2-3 months, we used to spend a day or two in the communities that help to teach our residents, recognizing what a gift that is. And so we would often come and bring lunch and also nurture those relationships in a way to build reciprocity so that the communities can help teach us what we need to know and how we can do better. With Kerry Sekani Family Services, they are a site for our residents and have been for quite a while. I was actually the first resident that went up with Dr. John on his tour. I actually grew up in and around lots of northern BC, so I was born in Prince George, but I grew up and spent many years in Lake Babine territory in Grand Isle and Tatchet. And so I was in my last year of residency and I went up with Dr. John and we actually stopped in Old Fort, which I hadn't been to since I was a little girl. And we went to Tatchet where I had lived for many years. And so it really felt like a coming full service or coming full circle for me. And certainly when I was growing up, we didn't have access to a physician at all. And so for most of my life, I didn't actually see a physician. We had Nurse Jenny, who provided much of our primary care. And so it was really great to see this service. And it built upon some of my dreams around how we can bring healthcare to communities. I did my medical training in Alberta, and they have much larger communities. And so sometimes would have large clinics with multiple doctors working out of them. Some of them had like small hospitals. But I knew in my traditional territories, our communities were quite spread out and quite small. And so thinking of a multidisciplinary group who could bring care to communities was something that I was really passionate about. And so when I graduated, I joined the team. And have been working with them ever since. And you know, when the pilot idea for this primary care team was pitched, it was both doing outreach at least around monthly, and then following up with telehealth, which was actually quite novel when Dr. John started this, I think 11 or 12 years ago. And so in order to build that continuity. So knowing that we may not be there every day in every community, but how can we still reach in and connect with our patients and follow up with them in a timely way? And so when they first did the first evaluations, they found that people's trust in their in physicians and in accessing care was actually quite low. And when we did our 5-year follow-up, we actually found that it went from less than 50% of people trusting doctors and when they act and the advice that they were given when they access care to over 90%. And that even though many people were hesitant about telehealth technology, many people became much more comfortable with it over the course of the 5 years and really valued the access that it provided. And even today, most days we have same day access. We do cover for one another on the different communities. So you may not necessarily see me or Dr. Lou, but we all chart and work together, and so we can build on the care plans that have been developed and connect with their regular doctor as needed to ensure that we're all working together. And we also get to work at a mix of larger care teams like mental health workers. We now have physiotherapists who work with us. We have social work services, some legal services. And so we really have access to many tools. And our Sekani communities have been really gracious teachers for our Indigenous site residents. And so some of the core principles that we work around on how Sekani and the Indigenous Family Medicine Program work to address healthcare disparities is by using tools from the ethical space of engagement. So ensuring that we get to know our communities, and we get to know what it means to be a carrier, a Deketh person, or from being from Stelako First Nations, in the context of understanding the history, the of colonization, as well as ongoing colonialism, and the impacts that has on health. And certainly in the Indigenous Family Medicine Program, we have curriculum around this to help form a base, but also encourage and acknowledge that that doesn't replace connecting to the communities that you serve and learning that traditional or learning their individual history, and what is important to them when it comes to their health and well-being. And then the value. So initially, respect, reciprocity, and relationship. And then in recent years, reconciliation and responsibility has been added. And so just the idea that, to treat one another with respect and as equals, that we all deserve a high level of care and consideration, especially when we need it the most. And that the idea, it's a two-way street, so of reciprocity. And so often, like Western medical or Western medicine has been very patriarchal and hierarchical, in that there has built in a power imbalance, but really it should be a conversation, and we should be walking alongside our patients and learning from them, and taking their direction on what they need for their health and well-being. And we have our toolkit and our toolbox to help with that journey, but really just as we have information and knowledge we can share with them, we should also be learning from the communities that we serve. And that, we can't transfer relationships. So it's important for us to stay and to be consistent, and to build some of these relationships over time, to build that trust. And so I wanted to focus a little bit on this talk on the barriers to kind of tie into what Dr. Lou has shared. And I really appreciate how the type of ally that Dr. Lou is, and how he's very cognizant of how he takes space and how he shares that space in a way that helps to call in his colleagues. And I think that that's really important. And also the emphasis that he takes away from it being an Indigenous person's problem, but really how we need to own and rectify some of the system and personal biases and structural violence that we see in our healthcare system. And so with the barriers, he mentioned the social determinants of health as barriers, the intergenerational trauma and high adverse childhood events, and the effects of systemic racism. And this includes even things like gaps in research. So, in academic medicine, when we talk about clinical trials and bench research that helps to eventually inform the medicines that we use, our clinical practice guidelines. Just acknowledging that there are many barriers of the type of people who are involved in those clinical trials, and some of those barriers are Indigenous versus non-Indigenous people, but also rural and remote people tend to be excluded, Northern people tend to be excluded, and so depending on where you're from, you have multiple levels of barriers. And so really some of our implicit biases in medicine are fundamental, built in from the research up. And so even our clinical practice guidelines may not even reflect good practice for Indigenous people. And I highlight that point to say, it's not just it's not just the interpersonal, but it's built in at all levels. So even docs who are really called in, who really want to do a good job, who really can practice from kindness and compassion, can still be perpetuating these structural and systemic biases that they may have little control over. And so that's why I think it's really important that, yes, we need to work on the interpersonal connections and our own biases, but we also need that, we need to work from it from a bottom up, but also from a top down, so that we can start to address some of these system and structural biases that can have a legacy effect of decades. So lots of this clinical research takes decades to come out. And so we need to start now to start ensuring that our clinical guidelines down the road are actually more reflective of our populations. And then again, a barrier is this implicit bias. And so I did want to talk about one thing that we can do each as people in our lives, but also healthcare providers or educators. It's just the idea of taking a racist anonymous approach. And so even though this idea has actually been coined multiple times, this reference comes from an African-American preacher who did a lot of cultural competency training in the US. And over the course of decades of doing this, he really began to wonder if he was making a difference. When he started doing pre and post bias assessments, he realized that sometimes giving people more knowledge, especially when they're not ready for it, and when they when they're not in a place to absorb it and to reflect on it in a good way, we can actually make things worse. And so using a racist anonymous approach is like a 12-step approach where we say, hey, actually, we're all racist, we're all sexist, we're all biased in some way. We each have a family of origin, we each were born into a particular worldview. And those can clash with one another and they may not be aligned. And especially in a Western context, due to the legacy of colonialism, the racism and sexism is embedded. And so we cannot not be racist and sexist. It's been inundated in the TV shows we watched, the books we read. And so we need to be cognizant, and we need to remove the shame and blame from it, so that we can actually uncover and be reflective of our biases, so that we can actually choose to act and respond differently. And so as highlighted here, it's essentially saying, let's end racism in ourselves first and then see what happens. And so that kind of reflects the comment I see in the chat around, really does, like, we have a lot of influence by starting with ourselves, our own families, and building out from there. Because, because we need to be able to do that work as well as the system work in order to make the biggest impact. And so in healthcare, one of the ways that we talk about this is by being reflective practitioners. And so reflective practice is a process by which you stop and think about your practice consciously, analyze your decision making, and draw on theory and relate it to what you do in practice. And so the key part of this is that you stop and think and reflect on your interactions that you have in healthcare. And do so in a way that challenges some of your decision making, challenges some of your perceptions on how things have went, so that you can slowly peel back and uncover how implicit bias may be affecting the care that you provide. And so I think that like this process is really important. It's even more powerful in a group. And one of the ways that we do this in the UBC Indigenous Family Medicine program is by using the medicine of sharing circles. And so we check in whenever we meet about how we're doing, about things that have happened since the last time we met, about maybe difficult interactions or good interactions, um, and and we mirror back to one another what we see and hear. And in that way, we can help all of us move along in our journey. Um, and particularly when we work in environments and systems that don't support us to be anti-racist yet. This part is really important so that we always remember. I'm sure I'm running out of time. So the last kind of program or service I wanted to highlight was that been highlighted or that has been stood up in the last year due to COVID is the First Nations virtual health services. So the First Nations Doctor of the Day, which is a public facing program where you can call in if you've lost access to your family doctor or never had access to your family doctor. And so we definitely try to reattach people locally, but can provide interim services if people are experiencing gaps and need to access healthcare. And we also have an onboarding process, so we're recruiting docs who have demonstrated they have some skills and insights to work well with our people, as well as ongoing cultural safety and humility and anti-racism training. And then we have the First Nations Virtual Substance Use and Psychiatry Program, again, understanding that we're in dual public health crises, including the opiate epidemic, as well as realizing just we already had such a huge need for mental health services, and now it's even more pressing. And so we can access through a referral process to get access to these services as well. And we hope to tie them into some of the primary care initiatives that are happening across the province, so we can again build on this idea of using virtual care to improve access, but having it bedded in that good in-person, not impersonal, in-person care to help build those relationships. And so I will stop there.
Awesome. Thanks very much, Dr. Aldred. I appreciate the presentation and and you sharing your experience and some of the work that's going on with Carriers Academy for Family Services, as well as the Indigenous Family Medicine Program. I appreciate that. So we have a couple questions that are kind of short technical questions I wanted to run by you, and then again we'll move on to Dr. Ho. The big one being, who can is the FNVSUPS, it's a long acronym, free? How many sessions are we allowed? Is it long-term counseling, or is there some sort of is it meant as a bridge to another service? You know what I'm saying?
Yeah. So right now the service is connecting people to either addictions doctors or psychiatrists, which are doctors who specialize in mental health. And so however, we are building out on the service, and so we have care coordinators that, depending on what your needs are, we can, like if it's counseling or psychology, even though we don't have those people as part of our program yet, although we are looking at building them in, that we can also help facilitate connection with other services as needed, including like through our health benefits pathway and through our local and regional connections. Many of our FNHA regions have set up some kind of what they're calling crisis support due to COVID, but it's really like essentially ensuring that people who need access to services in a timely way, that they kind of built a team to help kind of coordinate and connect patients to those providers, because understanding that COVID may have disrupted many of our ways that we keep ourselves healthy and well, and maybe many of our connections to our local care teams in a very holistic sense.
Right. Okay. Awesome. Thanks very much. And as I mentioned before, we'll come back around and have Dr. Aldred join us for our kind of our roundtable discussion at the end. Dr. Ho.
Great. Thank you very much. Really appreciate and I feel an honor to be able to participate in this learning circle. So thank you very much for inviting me, Cole, and I really appreciate everyone around the table. My name is Kendall Ho. I am an emergency doctor in Vancouver General Hospital for over 29 years. And also I lead a unit called Intercultural Online Health Network. I really feel honored to be here following Dr. Liu's excellent presentation about some of the issues, some of the affirmation of challenges of the health system for Indigenous community members. Also very fortunate to follow Dr. Terri Aldred. She has been a tremendous teacher to me in understanding some of the issues and how do we go there. And so today I come to you as a settler. I come to you as a person who have the privilege of living in Vancouver, which is the traditional and ancestral territories of the Squamish, Musqueam, and Tsleil-Waututh territories, and the privilege of coming to you as a learner. And so what I'd like to do is spend next 10 minutes or so. I understand we may be a little bit short in time, so I want to shorten my presentation a bit for two purposes. One is to thank you and to thank many Indigenous community members who have helped me in my journey through the last while. And I'll show you some of the turning points I have, and also show you some of the colleagues and members who've taught me very, very well. I also continue to learn this lesson. The second purpose is how do we work together to continue to do this? It's very important for us, especially in acute care, in hospitals. We lag behind community care in providing type of services that our Indigenous community members need. And even before that, many, as the statistics show, many of our Indigenous community members even don't want to set their foot into acute care. How do we do this? How do we improve ourselves so that this system is helpful to all of us, and very importantly, helpful to our Indigenous community members? Cynthia, may I ask you to start my slide? Maybe let's go to the next slide. And this case was my turning point. And whereas in school, I learned about, caring and also the importance of emergency departments serving everybody. This opened my eyes, this case in 2010. I have an Indigenous person who got into a car accident. In fact, the car was pretty badly crunched up. Very fortunately, he wasn't harmed too much. Yet he was brought into the emergency department with a collar in his neck to protect it because he was complaining of some neck pain. And so I examined him, I talked with him, checked things out. There's some neck pain, there's some chest discomfort, but by and large, thank goodness, he was very stable. And so I suggested him, well, I think we need to do some x-rays of your neck and your chest. And he said something that I didn't forget, never forget, and continue to help me to keep in mind. And he said, Dr. Ho, I respect what you recommend, but I would like to be treated by a traditional practitioner. And so that opens up a next conversation, the next 15 minutes, where I was trying to understand what he meant. And I didn't know much at all about traditional practitioner. And he was very articulate, and he was, again, very helpful to educate me about what his perspective was. And so after 10, 15 minutes, I realized that X-ray is not the right thing for him. And so I said, nope, let's not go for the X-rays or chest X-ray. Explain a little bit of risk, but I think it was a low mechanism, and so the risk was low, but I couldn't completely rule out the any fracture. And so we parted company. And on that day, I learned a lot from this individual. I still am very grateful to him. And subsequently, I found out a few things. One is that if I were to call an Indigenous practitioner to the emergency department, there wasn't a mechanism at that time in Vancouver General Hospital. Secondly, I also found out that if we were to do that, I, as a physician, would be, quote unquote, permit or authorize that to do so. And I was in fear because I knew nothing about traditional medicine. I feel not prepared. I could not even understand how to really do that. And yet that responsibility was on me. And so that was a reflective journey. That was a very important point for me to figure out I better learn something about traditional practice. I better start to understand more and more of what my Indigenous community members need when they come to emergency. To call myself trying to help anyone in emergency. If I'm not doing that, I'm not doing my responsibility. And so the next 10 minutes, I'm going to show you some of the journeys that I've gone through. Again, I want to express my thanks to you and many of your Indigenous community members and elders and traditional practitioners that educate me as we go forward. Next slide, please, Cynthia. I'd like to take this moment because of 2010 that I was able to start on this journey, and I was able to connect with different elders and different groups. And this is one of the elder from Musqueam, Elder Shane, who actually participated in creating a video. And this video was in fact, in some ways very selfish because I need to learn more about traditional practitioners. And I know that many of my colleagues would benefit from this too. And so as an Intercultural Online Health Network, I'll talk a little bit more later, we decided to produce a video, and there are many great traditional practitioners that joined us, and Elder Shane joined us in opening. And could you play this video, which is about half a minute or so? Cynthia, thank you.
Welcome here. Welcome here to this place, this sacredness. I welcome you here.
I really appreciate that a lot. And in engaging with our Indigenous communities, our elders, they have always come with welcome. And they've always come with open arms. Despite the challenges that we see, the statistics that Dr. Liu showed, the community continue to welcome us as settlers. And I appreciate that a lot. And I can't say more than just keep repeating the expression of appreciation. And secondly, I really appreciate not only the music itself, although I don't understand the word, but the time that the talking circle take, the time that people take. As opposed to my busy life, I keep running around. And I think it comes back to what Terri talked about, Dr. Aldred talked about, the reflective practice. I think those moments of slowing down help me to reflect. So I really want to thank you and our Indigenous communities for that very important lesson, and elders like Elder Shane to show me that. Next slide, please, Cynthia. I'm also very fortunate to engage and be learned and be taught about different ways. And Elder Jerry Ullman was there very soon after I had that case. And I was able to sit down with Elder Ullman and start talking about some of my challenges, some of my issues that I need to learn. And he was very kind and open and talked about his experience as a traditional practitioner, as an elder, when he went to Children's Hospital in BC, went to St. Paul's or VGH, what he did as a traditional practitioner, how he used music, smell, prayers, and also simple kindness to do those therapies. So again, really appreciate his leadership and show me how this was done and start my journey and learn about traditional practice. Next slide, please. And with that, I had an opportunity in my position as the lead of the Digital Emergency Medicine Unit, and also as a program that we've been working with Ministry of Health, patients as partners. We started a program called Intercultural Online Health Network. We started in 2007, starting to look at Chinese and South Asians, but the multicultural communities. How can we support our patients, especially those who don't speak English, so that they can get the type of information that they get to improve their own self-management? And how can a health system be more responsive to it? Obviously, the Indigenous community is not multicultural. The multicultural communities are settlers in this country. But with that opportunity, I had the opportunity to talk with the Ministry of Health, and they very much supportive of us starting to look at in the Indigenous communities, how can we as health professionals learn to support our Indigenous community members to get the best of care that they can. And so my journey started with that organization. Next slide, please. And with that, I was very fortunate to be engaged with Leslie Bonchar. Leslie at that time was the lead of the Aboriginal Health Program in Fraser Health. And so I started to be able to be invited to the solo communities. And also in the Fraser Health, they had an annual Indigenous conference. And so I started to learn. And these are the things that I learned, that in fact, in community engagements, that the community opened up to welcome me. And I appreciate that, because that first step, I couldn't have done it by myself. The community was welcoming. Secondly, it's about building relationships. It's about building mutual trust and mutual understanding. And with the Indigenous community's hands open up, it's easy for me, much easier for me to be able to then shake that hand. And so I want to thank those communities for doing that. And then with that, really, I need to listen. I need to learn. I need to then understand what are some of the issues and dialogues. And then with that, we then move forward together. And I use what I can to support, but I draw back to the communities and the wisdom so that I can then, in some ways, socialize with my colleagues. Next slide, please. And so with that, one of the things that we did was that video. That video was a 11-minute video. If you go onto the ICON website, you can see it. I welcome your feedback to it. It's really an introduction. It's not about the encyclopedia of traditional medicine, far from it, but it's a portal to open up for me and my colleagues who don't know traditional medicine to have a sense about that. But then with that video, we were welcomed again with working with Island Health and First Nations Health Authority to Vancouver Island, so that we went to several communities, and the communities host these sessions. And with these community sessions hosting, we also engaged the health authority leadership and also physicians and nurses, so that we went to the community, such as the one that you saw here in the Saanich Peninsula. Elder Oldman chair and moderate the discussion. And really it's about health professionals understanding what the community needs are, understanding the community's perspective on health and wellness, and how can we as a health system, acute health system, acute care system, support that wellness. If you're interested in BC Medical Journal, we have chronicled that particular activity there. Next slide, please. And so with that, very fortunately, since 2019, we continue to build our relationship from Fraser Health, First Nations Health Authority, Island Health, to now Vancouver Coastal. And it's very, very fortunate. And in fact, it may not be fortunate. Maybe, in fact, there is some force behind it. Leslie Bonchar now is the lead of the VCH, Vancouver Coastal Health Aboriginal Unit. And so by able to work with Leslie, and we were able to start some acute care rounds or Aboriginal health rounds in Vancouver General Hospital and also Vancouver Coastal Health, so that we welcome members to join together. And these are elder-led and also traditional practitioners-led. And I moderate some of those sessions, but in fact, again, being very selfish, by moderating, I learn a lot from these sessions. So we discuss some of the acute care issues and how do we move things forward. Next slide, please. And so with that, we are also, the Vancouver Coastal Health has produced materials about Indigenous health for health professionals like myself, so we can learn more, and also materials that are co-produced and in fact led by the Aboriginal Health Unit in that production. And so we want to make sure that these materials get disseminated to our health professionals together. Next slide, please. And so these rounds that we have been doing, we were able to invite health professionals to join. Is really to understand how can we work closely with our elders and the traditional practitioners so that we can support the health and wellness of Indigenous patients coming to acute care and also connecting with community care, make sure that they get the best care. And very fortunately, we are also working with Terri and the First Nations Health Authority. In fact, she was one of our speakers in our round in February. And in fact, in the last year, we've been very fortunate that we have over 300 people coming to these events. In fact, out of those, approximately, you can see the percentage of people interested in the content, and 70% or more are health professionals, nurses, physicians, social workers, wanting to be there and hear and learn together. And so I think there's a very willingness of us wanting to learn. We don't want to burden our Indigenous communities. We know that there's a lot of history. There's a lot of healing that needs to be done. But I appreciate those who open up and support us so that we can learn as settlers. We can learn to help and move things forward together in a safer environment. Next slide, please. I believe that's my last slide. I really want to thank you opening up this learning circle so I have a chance to share with you my journey as a settler. These experiences help me to anchor myself, and these experiences anchor many of us as health professionals to really learn and ground ourselves, understanding how Indigenous communities and members' needs are, how do they look at wellness, and how do we learn about wellness, and how do we best support them. I want to thank Ministry of Health, Patients and Partners, allowing me a little bit of an avenue to be able to spread this. Vancouver Coastal Health, Aboriginal Health, and also First Nations Health Authority, of course, Terri, working closely with you, moving things forward. And Vancouver Coastal Health Leadership. These are individuals who really help move the organization, say this is important. We got to pay attention to it now. And also I want to thank my Lower Mainland Emergency Department colleagues, Dr. Grafstein, Dr. Keller, who, because of in plain sight now leading in the Lower Mainland in the Vancouver Coastal Health to figure out how can we make emergency department a safer place. We know that we are far from being safe, but how do we make it better every day? And again, thank you for your interest to want to help us to make acute care safer for you. Our next round is on March 24th, 12 noon. Everybody's welcome to join. And if we can have your voice there, it'll be amazing for us to continue to learn together. Thank you very much for your attention. Thanks, Cynthia.
Awesome. Thanks very much, Dr. Ho. I appreciate your presentation. It's important to recognize that the different people are going to have different journeys as it relates to learning about Indigenous health and well-being and what traditional medicines can, the sort of impact that it can have in an Indigenous patient's care. So I appreciate and applaud the work that you've done in ensuring or at least attempting to make sure that body of knowledge is recognized in a holistic system of care. Thank you. So we're going to transition over to our Q&A section at this point. So the first question that I wanted to kind of throw out there, just for everybody, whoever would like to take a swing at it from the panel, what are your thoughts on resetting the entire system of care? What would it take to hold everyone accountable and who they need to be when they need to show up, and who they need to show up to work in healthcare? So kind of opening it with a broad question. What are your thoughts on it?
Maybe I'm happy to jump in. I understand the perspective of that question, absolutely. I think there are many things that we need to correct in our health system. I think there are some fundamental pieces in the health system that are also very important and very necessary in terms of, for example, evidence-based medicine care, etc. And so I think it's about how do we transform our health system. And transformation does not necessarily mean tearing everything down and rebuild, but transform is to figure out what's wrong. And we absolutely shine light on what's wrong and work very, very, very hard to correct what's wrong, but also understanding what's right. What are some things that's been working so that we continue to preserve what's working and bring what's wrong and the solutions to merge with what's right so that we can transform the health system. And so that's how my perspective is, and I welcome others' perspective.
Yeah, I mean, I think looking at, culturally safe and trauma-informed spaces, and how to I guess, build those principles into our facilities and into our clinics is really important, so that people feel feel welcome and feel like the space, you know, was designed with them in mind, so they can see themselves in it, is one thing we can do. There's been a lot of effort around increasing admissions of Indigenous students, which I think is key, so that we have Indigenous people in all departments at all levels, and others. So a broader equity, diversity, inclusion lens is really important. You know, the data which suggests that until we have good representation at all levels, including senior leadership, as well as in all departments and different things like that, from a full spectrum of diversity perspective, that once that is achieved, then generally the good systems change, and including changes that help to promote equity, diversity, inclusion starts to happen. But that it can be really challenging to achieve. And one of the things I see in our educational institutes, as well as places where we practice, is that the emphasis is kind of getting people through the door, and then there isn't a lot of supports for them once they're through the door. And that can be really discouraging for people as they're interacting in spaces that are harmful often to them, where they're witnessing often racism or other violence on a day-to-day basis. And then there's things around like meritocracy that also puts an additional burden. And when we look at it from a social or from like a health determinants, Indigenous people, in order to get through the door, often had to do a whole bunch of work that many others didn't have to do. So it's the idea of needing to shoot from the back of the classroom, that they can still get through the door, but it's a little harder to make that shot. And so, yeah, so anyway, so making sure that there's supports all the way through, so that people can feel more comfortable and more confident and have less trauma going through the experience, I think is really important. And I think looking at it from this, again, talking about the systems perspective, so when we have high functioning systems where people feel like they're doing a good job, then that can really help to address burnout and different things. Burnout negatively impacts patient care. We know that for all patients, but I can't remember specifically if Dr. Liu mentioned this in his talk, but I know he has in the past, around different things that actually make us situations where we get more biased. And certainly if we're under stress, feeling burnt out, then we're less likely to act at our best, whether or not that is being more biased or whether or not that's just where we lack the ability to be kind that day or to be compassionate. And so I think when we have high functioning systems that hopefully support that make the providers feel less burnt out, then that can also translate into better patient care. And then I think the biggest thing is around accountability structures. So we need ways to be able to collect information from patients, so that like the direct harm is reduced, so that those how the biases affect, so like underdiagnosing, undertreating. We need fail safes and processes in place so that stops happening. Like people are getting hurt, and some people are dying because of these things. And we need to do a better job at providing checks and balances so that vulnerable people who are more marginalized are not paying for the consequences of the failures of our systems and our colonial structures. Yeah, I'll stop there.
Thank you very much for that thorough response. And I wanted to say, Dr. Ho, I appreciate your lens, because yeah, you don't throw the baby out with the bathwater, so to speak. But certainly, yeah. Dr. Liu, did you have something to add?
Thank you. I think it would be a very multifaceted, multi-pillared approach. You know, I think we need to reach that critical mass, and we need change makers. We need people to radically lead charge. We need, you know, we need to continue to support and you know, foster the Indigenous leadership and the whole conversation to lead that change, and I think as well in the same time ensuring accountability. So you know, putting in place ombudsperson mechanisms, etc., to ensure accountability as the school scenario shifts, and as well, I think also engaging the existing powers through conventional methods, like for example, using, you know, change management strategies, using knowledge translation. So you know, basically these practices that, you know, that have been contributing to the current power structure may in and of itself lend a way into helping to change that current power structure as well.
Right. Yeah, absolutely. Thank you all. So before we transition to my next question, I just wanted to highlight a comment that we had. Thank you so much to the panelists. As an international medical graduate, it's such an eye-opening journey to learn about Aboriginal or Indigenous communities. It's difficult and painful to hear about the challenges faced. And they thank us very much for an informative session. I just wanted to highlight that comment because I think it's a critical piece, and Dr. Aldred has spoken about it here. We've all spoken about it, the role of allies and proper allyship, and making sure that we all work towards a systemic change and a betterment of our healthcare system for Indigenous people. It's critical. So I just wanted to highlight that for both your Dr. Ho and Dr. Liu yourself as well. So transitioning to the next question here, it's from Denise. So we as Indigenous people get asked about how non-Indigenous people can deal with this difficulty, the pain and the guilt. And I think the question is more directed toward Dr. Aldred, but how do you continue to work through this difficulty, the pain, you know, the guilt as a settler physician, you know, and the shared experiences, the shared troubles for Dr. Aldred. It isn't for us to share our lived experience and then turn around and also come up with strategies on how to deal with that experience when you find out and learn. Does anybody have any thoughts on that?
Yeah, you know, like I would say, so part of it, you know, becoming an ally or an accomplice is a journey. And as you go on the journey, I think it's important to always remember to be humble and to acknowledge that no matter what sort of expertise that you develop, it doesn't replace lived experience. And so always remembering to include those voices and bring and know when to essentially pass the mic. So you the reason for allies and accomplices is one, to help promote safety, and to also do that learning with people who look and come from your backgrounds, especially. And so I remember seeing another comment around, I think it might have been this one around the shame and blame, you know, or Indigenous people taking on, you know, the responsibility of fixing this. Like, this isn't an Indigenous problem, this is a Canadian problem, and we all have a role. Particularly looking at like whiteness or at racism at large, and privilege. These are things that, you know, people can be critically reflective. So I don't need people necessarily to understand and promote what it means to be Indigenous. What I need people to do is to sit back and realize what kind of privilege they hold, what kind of power dynamics that may play out. What does it mean for a space to be white centric? And so, you know, and that's kind of, you know, the work of being allies and being able to bring their colleagues along, being able to call up, to have that speak out culture so that people can call in their colleagues when they can, and call out behavior when it's inappropriate. And the shame, the guilt, and all of that is very very real. And I think developing skills around shame resilience is really important. So the book like White Fragility kind of highlights some of this, is that it's not the responsibility of people of color or Indigenous people to make people who are racialized as white feel better. Necessarily. If we have capacity, absolutely, some of us are comfortable holding space. But it's developing some of that resiliency within ourselves, that when, that kind of shame comes up and things like that, how can we help manage? And I think it's really important that we move away from, targeting people as bad, but more targeting, behaviors and thought patterns that are problematic and things like that. And realizing that, we were handed this. It's none of our fault that our systems are racist, but we do all have a responsibility. And so that's why I like the Racist Anonymous approach, because it's not us and them. It's not, oh, I need to be good at calling out racism because all these people are racism, but I'm not. Like, it's really important to think about it holistically. So how can I call out my colleagues gently if I see harm being done, or call them in? But also, how can I build up my resilience in case somebody says, oh, I witnessed this and I don't think it landed well, or when you mentioned that kind of hurt my feelings. Like, we need to be able to have these really tough, courageous conversations, because that's where the magic and the healing is going to happen. And if we can't build up the emotional intelligence to do that, it's going to be really hard to make room in this, to make headway, because we can't effectively address a problem that we can't talk about, that we can't pinpoint, that we can't say this is the issue. We can't develop metrics, we can't develop accountability. And so it's really important that we can build this, but we each have our own responsibility on how we show up and how we react to this, and we can't put that on other people. And I will say, allies and accomplices, as you go through, you're going to be held to account. Like, people are going to know, and they'll be like, I know that they can take it, so I'm going to hold them to account. And so that's why it's always important to stay humble.
Mm-hmm. Yeah.
If I can jump in for a short comment, I really appreciate Denise your point, and I absolutely can feel the challenge, in terms of magnitude of the problem. Maybe two comments. One is, I know that I really benefit from the authentic sharing of community members like yourself. I mean, just sharing that question is a tough one to share. So I want to recognize that very much. And two is, in some ways, when I think about some of my best friends that I talk with, some days they're not ready to talk. They say, Kendall, today's not a good day to talk. I really need to sort things through. But friendship, it's about when you're ready. I love to hear it. I love to understand. I love to really build up this relationship. I think the relationship is going to be pivotal for us to be able to work together. Some days, I may be doing something for my very good friend, and he or she would say, yeah, you did it, but you did it pretty awkwardly. I didn't really need you to open the door for me, but you did, but that kind of very awkward. That type of authentic exchange is very important for us to know that as a settler, what I do, I try, but there are certain contexts I don't understand. And so your friendship, your relationship will be so important to help me to continue to calibrate myself over time. And I hope those two comments are helpful in a sense that that authenticity that you display, the relationship that we can build, and holding me to account as Terri, are three really important components that underpins how we can change the system.
Mm-hmm. Yeah, absolutely. What you just said reminds me of the slide that Terri showed, where you're talking about, respect, reciprocity, and relationship as being kind of integral to going about this work. Dr. Liu, did you have anything else to add?
I think it's very well covered. I think humility is extremely important, and I think taking ownership of respectful ownership of the discomfort and the need to own to take part in the solution. I think that's really key. And whatever discomfort that comes with that, we have to own that.
Awesome. So I'm going to ask one more question, and then I think that will probably be all the time that we have today. But I think it's a great question to end on. So I can see a tension between a decolonial approach that is community-centered and based on rebuilding nations, including traditional roles that rely less on the Western medical system in the sense that they exist independently of that system, and an approach that could be described as more assimilationist, with bringing more Indigenous people into the existing system in order to improve it. At the same time, this might not be a tension or a conflict necessarily, and could in fact be something that, two mutually reinforcing goals. And I'm wondering how each of you, from your perspective inside the medical system, would understand health and wellness from a standpoint of decolonization as it relates to those previous points, this kind of tension or piece between these two approaches.
Maybe I'll jump in from my lens again. Really want to put my thought out as a learner. So, in my role in trying to change system, we always talk about the health system being very complex, and how do we make a complex system change? And often it needs three things as principles that each organization themselves self-organized to do what's best for that group. Secondly, for all the organizations involved to what they call sense making, to understand what others do and how does that contribute to the bigger picture. And then the third is to realize that as we move forward, there's always interdependence. Not one organization can do it all together, but together we can. And so I think the importance of decolonization is very important. The assertion that this is important, we need to move forward. And I think the assimilation, or if I use your word, so that we have members to be in the systems to continue to change also the different organizations to move forward. Those are very important. I don't use it in a negative way, transactional piece. That's absolutely necessary to happen. But I think what really changes a system is not only do we have a safe relationship so that these transactions are mutually beneficial, but we all turn our face to where we want to be in the future. It's that point that we said we want to go there together, that I think the different organizations start to sense make, starts to go beyond transaction, become transformation, because they all feel that they're interdependent, they need each other to get to where we need to go tomorrow. Hope that helps.
Thank you, Dr. Hope. Yeah. Sorry, Terri, go ahead, or Dr.
Oh, no worries. Yeah, so I absolutely agree. And I don't think it's an either or, but a both and. I think self-determined spaces are really important. And so thinking about the, Indigenous Family Medicine program, Sekani, like those are self-determined. Our communities asked for this. The Indigenous Family Medicine program was designed because there was seen a need to build people who had more enhanced skills to work well with our communities. And the FNHA will have 15 of their own primary care initiatives that are independent and built by the nations that they're intended to serve, which is a different process than the PCNs, which are engaging with First Nations. And so I think that self-determined space that's rooted in Indigenous ways of knowing and being, I think is very important. I think it's very important that we keep it as walking alongside and really working on those intersections and how it's translated, because for me personally, I don't want to see a segregated system. You know, if we look at Indian hospitals and TB asylums, wasn't a great system. And so we want to, for me, it's just, and so people are given the tools and autonomy and choice. And that it's not that they only have access to this or that, but they have access to the full bandwidth. If they want all that Western medicine has to offer, they can have that and have an elder or and use traditional medicines. You know, for me personally, like I seen a comment around two-eyed way of being, like, you know, oftentimes in Western medicine, they're like, which hat are you wearing? What perspective are you bringing? I'm like, I'm just Terri. I'm a Decath, Indigenous, Western trained family dog, and I bring all that complexity with me. And for me personally, I feel more comfortable utilizing kind of that prevention lens, traditional medicines, food as medicine, you know, accessing healers and things like that. However, when I get acutely sick, I want the antibiotics. And, you know, if I were to walk out and get hit by a bus, I would want them to pull out all the stops, you know, but then I would, you know, once I'm through the acute phase, I would want to look at my whole medicine wheel again. I would want to talk to my elders. I would want to, you know, have good medicines to help rebuild my strength. And so, you know, I think it's going to be different for all of us, but we have a right to have access and choice, and it shouldn't be predetermined for us.
Mm-hmm. Yeah, and the only way to really make that a relevant choice is to have both systems be equally held up and equally supported in a way that makes it accessible and breaks down the barriers that we spent the last hour and a half talking about. Dr. Liu, did you have something you wanted to add there? Sorry, I always feel like I come to you third. I apologize for that.
That's okay. I think my place as a settler is really to take a look at the public system and really acknowledge, respect, and affirm the fact that the public system as it exists also is owned by Indigenous peoples in Canada and also exists for the service of Indigenous peoples of Canada, as well as other peoples in Canada. And I think that, and I think self-determined space is also very important. And you know, and I think for settlers, for people who are outside of those self-determined spaces, I think we must you know, take the responsibility to ensure that as people step outside of those spaces into the public spaces, that it continues to be one that is built responsively for everyone, and then turn around and be ready to support and work with the self-determined spaces as we are permitted or invited to do so.
Mm-hmm. Yeah, absolutely. So I recognize that we've gone a little bit over time, so I don't want to keep any of you any longer. I wanted to end by saying thank you so very much, Dr. Aldred, Dr. Ho, Dr. Liu. I've really enjoyed our conversation here today, and I hope that everybody that's watching along has as well. Judging by the chat, I would say that we have had a really engaged and informative session for everyone. So thank you all very much, and thank you to everyone that joined us here today. Learning Circle is going to be a little bit quieter in March. We're looking forward to having Dr. Margaret Kovach join us for a session on Indigenous research and methodologies. That'll be later on this month, and we're looking forward to seeing you there. Until then, everyone take care. Thanks again so much for your time, and yeah, be safe.